Welcome to Mayo Clinic's ECG segment, Making Waves, continuing medical education podcast. Join us for a lively discussion on the latest and greatest in the field of electrocardiography. We'll discuss some of the exciting and innovative work happening at Mayo Clinic and beyond with the most brilliant minds in the space and provide valuable insights that can be directly applied to your practice. Welcome to Mayo Clinic's ECG segment, Making Waves. In this episode, we explore an emerging procedural strategy in the management of atrial fibrillation, combining pulse field ablation or atrial fibrillation ablation with left atrial appendage occlusion during a single intervention. As pulse field ablation continues to transform the landscape of atrial fibrillation treatment, cardiac electrophysiologists are increasingly asking whether combining rhythm control and stroke prevention procedures can improve patient outcomes. Dr. Ammar Killu is a board-certified cardiac electrophysiologist and associate professor of medicine at Mayo Clinic in Rochester, Minnesota. He earned his medical degree from St. George's Hospital Medical School at the University of London and completed his internal medicine residency and cardiovascular diseases fellowship at Mayo Clinic. He subsequently completed cardiac electrophysiology training at Brigham and Women's Hospital, Harvard Medical School, before returning to Mayo Clinic as a Mayo Scholar to complete advanced electrophysiology training. Dr. Killu currently serves as director of the Left Atrial Appendage Occlusion Program and is the Director of Trials and Innovation for the Division of Heart Rhythm Services here at Mayo Clinic. His clinical interests include complex catheter ablation procedures, particularly endocardial and epicardial VT ablation, as well as novel device therapies for cardiac rhythm disorders. Dr. Killu, thank you so much for joining us today.
Thank you very much for the invitation. It's great to be here with you.
You know, we've tried really hard and we finally found a time to bring you on. And I think this is a topic that many patients that we get asked about in the clinic, you know, whether it's first time, and even amongst our colleagues, a really hot topic. And so we wanted you, because you lead our program here, to kind of help us out to understand this. And so I think what would be helpful is, you know, as we think of AFib ablation and now the appendage occlusion devices that we have, you know, why consider these and combining them in the same patient?
Yeah, so it's a great question, Anthony. You know, atrial fibrillation ablation continues to increase. It's the most commonly performed ablation procedure that we do. One of the potential issues that patients have with atrial fibrillation is, of course, the associated stroke risk. And so following catheter ablation for atrial fibrillation, current guidelines state that you would still remain on a blood thinner if you otherwise would require it from the stroke prevention aspect, whether you're in normal rhythm or not. And so left atrial appendage occlusion is a non-pharmacological, non-drug alternative that has been performed, you know, extensively across the world, especially in the United States, that has been shown in multiple studies to be a viable alternative. Now, obviously, without getting into the nuances of the data, which, you know, can be controversial between people, it is an option that we are, I think, obligated to give patients, especially if they do not want to be on a blood thinner long term. And so one of the kind of recent advents over the last couple of years has been this option to perform both procedures at the same time, and therefore allow a patient to come off a blood thinner following, you know, an adequate ablation and left atrial appendage occlusion procedure. While there's emerging data that suggests patients who are relatively low risk of stroke can stop anticoagulation after a successful atrial fibrillation ablation, there are a lot of patients that don't fall into that category. And so those patients who would otherwise need to remain on anticoagulation long-term may well want a different alternative. And that's where left atrial appendage occlusion is an option. Data can be variably presented based on which camp you're in, but generally speaking, the risk of stroke, ischemic stroke, if it's higher with appendage occlusion, is small. It's about a 0.3% risk per year higher. But the rates of bleeding have been shown in multiple studies to be lower. And therefore, that's why some patients prefer to go down that route.
And we've really seen a lot of it, like I mentioned earlier, patients in the clinic asking, even colleagues in cardiology mentioning this. We've even seen, as Dr. DeSimone has joined us recently, about this pulse field ablation and how it's rapidly changed how we approach AFib ablation today. It's the way I've trained is probably looks different than the way you trained. And so from your perspective, what advantages do you think that PFA or pulse field ablation adds compared when we think of conventional thermal ablation, and combining this with this ablation and left atrial appendage occlusion strategy?
Yeah, it's a great question. So if we just take one step back, the data that was presented to show that combining these two procedures is associated with good outcomes in patients was using radiofrequency ablation. It preceded the emergence of pulse field ablation in the United States, and so a lot of the data has been extrapolated for that. There are observational studies and retrospective data that have shown feasibility of using pulse field ablation at the same time for an ablation procedure followed by left atrial appendage occlusion, but there is no large randomized study that has been published thus far. Having said that, we know that pulse field ablation has kind of revolutionized the way we perform ablation. As you said, unfortunately, I am a bit older than you, so I saw the point-by-point era of radiofrequency and cryo, but with PFA, the procedure has really been democratized now, that the duration of ablation is a lot more standardized. We know that the safety of the procedure is better than with radiofrequency because of the minimal thermal change. We don't see pulmonary vein stenosis. We don't see atrioesophageal fistulas. Phrenic nerve injury is much, much less common. And by having a quicker procedure, a safer procedure, even if efficacy is the same, it's still a significant advance. And so that's why the majority of the cases when we do perform atrial fibrillation ablation with or without left atrial appendage occlusion, especially for first-time procedures, is utilizing PFA.
Yeah, it certainly has, changed the way probably the majority of our cases have gone with the PFA. Now, when you think of these procedures, certainly two complex procedures, it sounds appealing to just get them all done at once, same day, get it all, and you have them both done, and less stroke risk potentially, and maybe less AFib burden. But it also introduces unique technical challenges that I know you've mentioned before. What are some of those key procedural things that you're thinking about, or caveats clinicians should be aware of when thinking about these combined procedures?
Yes, a great question. So procedural planning is obviously paramount. So you need to look at the anatomy of the patient, not only with respect to the pulmonary veins and the atrium itself, but now also the left atrial appendage, which, you want to get a complete seal off to try and maximize the likelihood of benefit. So in addition to those things, you then also have to plan how your procedural workflow is going to be. In a high level sense, we generally will prefer to perform the ablation first, followed by the left atrial appendage occlusion, especially when we're using PFA. And so the general workflow that myself and a lot of my colleagues within the EP community do is we will first obtain detailed baseline imaging of the left atrial appendage and the dimensions, and have an idea of what kind of device and device size that you would want to use. Once we perform the ablation, you'll get some tissue changes, predominantly edema, so swelling in the region near the left atrial appendage that may actually change the dimensions that we would get otherwise. And so if we were only to measure following ablation, we may have a smaller size that we would pick because of the edema. Now, the problem that can emerge with that is once that edema and swelling, resolves, you then have a gap around the device, and therefore you may not have the same level of protection as you would if you have a complete seal. And so that's really one of the main aspects. The other reason to do the ablation first before the device is in is because with PFA, we're using electrical energy to disrupt the muscle cells. And so if we put the device in the left atrial appendage and then ablate, and there's contact between the two, that can result in issues and often will actually result in failure of energy delivery. So those are the two main reasons.
A lot of things of, how do we manage these patients with anticoagulation afterwards and the patient selection, and a lot that we haven't talked to, but we're going to probably leave those off because we want to have you back on here to share a little more about that. And so I want to thank you. And, today we had a chance to explore this growing role of combining pulse field ablation and left atrial appendage occlusion as part of a comprehensive strategy for managing AFib. We had Dr. Killu, who really leads our department here and is someone that we go to for, how do we do this? Which patient should we select? What are things we should think about when considering these procedures? And he certainly gave us some things to think about. What does the procedural sequencing look like? Some imaging things we have to consider, as well as things to think about during the procedure and that workflow. Dr. Killu, thank you so much for joining us. We always learn a lot from you. I always have enjoy working with you and hope you'll come back and share more with our community. Thank you again.
Thank you for having me, and it's been a pleasure being part of this.
Thank you for joining us today. We invite you to share your thoughts and suggestions about the podcast at cveducation.mayo.edu. Be sure to subscribe to a Mayo Clinic Cardiovascular CME podcast on your favorite platform, and tune in every other week to explore today's most pressing electrocardiography topics with your colleagues at Mayo Clinic.
This has been a Mayo Clinic podcast.
At Mayo Clinic, continuous learning fuels world-class care. I'm Dr. Thais Coutinho, Chair of the Division of Preventive Cardiology at Mayo Clinic in Rochester, Minnesota. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Please check out the link, cveducation.mayo.edu, and explore our live and online programs, quick on-demand modules, and CME accredited masterclasses created and taught by the very voices you trust here. Join thousands of clinicians who have already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.